The first question is about vascular events in inflammation. Delayed prolonged leakage following tissue injury is due to cytokine mediated vasodilatation, histamine, endothelial retraction, direct effect of the injurious agent. Okay. So, this is one very important topic because there are some 5 to 6 mechanisms by which the vascular permeability is increased. The vessels become leaky during inflammation. We divide the inflammatory events into vascular and cellular events. Cellular events we will be seeing in the subsequent questions. Vascular events, 1 or 2 MCQs are generally asked in all the entrances. So, there are different mechanisms. Okay. Among these, they are asking about delayed prolonged leakage. So, there are different types of leakages. Something begins early and persists for a very short time, okay, which we call it as early transient response. Begins quite early, immediately after the injury, the leakage begins, okay, and it is transient, it is for a very short-lived period. Just imagine what could be the mechanism there. It has to be something very quick, which can cause increased vascular permeability. So, the endothelial cell contracts. If the endothelial cells contract, there is a space created between them that will cause leakage. This is something that can happen very quickly, okay. So, this will cause early transient leakage. Whereas, in this question, we are talking about delayed and prolonged. The effect has to be prolonged. It has to be at least for 3 to 4 days, 2 to 3 days or 3 to 4 days, the effect has to persist. So, the damage should be substantial. So, in this case, the 4 options that are given to us is cytokine mediated vasodilatation, histamine, endothelial retraction, direct effect of the injurious agent. Option C is ruled out. Endothelial retraction, if it retracts, it will relax within a few minutes. So, the transudation will stop, right. But we want prolonged leakage. We want prolonged means at least 3-4 days leakage we want. So, endothelial retraction cannot meet, right. Histamine and cytokine mediated vasodilatation more or less same. They are referring to chemical mediators. So, for chemical mediators to come to that site and cause vasodilatation and increased leakage, it requires some time. Okay. So, how that is going to happen? First, basically what is going to happen at that site of injury, wherever injurious agent is damaging, the endothelial cells will become leaky. There is some edema that is setting up. Okay. So, because of leakage of plasma, the concentration of the intravascular compartment will increase. What will happen? Fluid will flow out. If fluid flows out, what happens? It will become concentrated. Cells are more, cells are not going out, only fluid is going out. So, it becomes concentrated. If the contents become concentrated, what will happen to the rate of flow? It will be fast or slow? It will be slow, it will become sluggish. This we call it as stasis, vascular stasis. There is stasis, right? It is not moving. So, because of stasis, there will be accumulation of cytokines. Cytokines will come, lot of cytokines will come. They will start acting. They have to get activated and then they will start acting. So, this also requires lot of time, okay. But this starts a little bit early only because the events would have started, the cytokines are local, so many cytokines are local, they are produced locally. So, they will start acting very quickly. But our mechanism here is not only prolonged, it is also delayed. It has to require time. So, the best option here would be direct effect of the injurious agent, whatever injurious agent it is. For example, say bacterial toxin, we have an endotoxin, okay. The bacteria is damaging, the lipopolysaccharide of the bacterial endotoxin is causing damage to the vascular endothelium. Its effect will be delayed also and its effect will be prolonged also, because if this endothelium is going to get damaged, it requires at least 3-4 days to regenerate, okay. So, the answer here is going to be delayed and prolonged. We will look at this table quickly, which tells us all the subtypes. First is immediate transient, which I told you starts early, very early, and it is very short lived, 15 to 30 minutes, only within 15 minutes it will begin, okay. The mechanism is endothelial cells are contracting. The cytoskeleton of the endothelial cells, the actin framework of the endothelial cells is contracting. So, as a result, gap is created. Who induces this? This is induced by the most important mediator, that is histamine, and the vessels on which it is going to act is post capillary venules. It is going to act on venules, okay. Please remember, these are again very standard MCQs. Histamine acts only on post capillary venules. It does not act on capillaries, it does not act on arterioles, it does not act on big vessels, it acts only on post capillary venules, okay. Other than histamine, what other mediators? Bradykinin can work, Leukotrienes, LTB4, LTC4, LTD4 can work in this mechanism. Neuropeptide and substance P. Neuropeptides and substance P. The important neuropeptide is enkephalin. Of course, neuropeptide substance P have other functions of producing pain. Not only increase vascular permeability, they also produce pain at that site. Okay, that's immediate transient response. There is one more response which begins early, immediate, but it is sustained for a long period. Immediate sustained response. This is because of endothelial necrosis and endothelial detachment. Okay. Right. So, we are talking about an immediate sustained response, which is because of endothelial necrosis and detachment. It is immediate and its effect is prolonged. This is seen in burns and lytic infections. Whenever there is a burn related injury, there is damage, necrosis and detachment of the endothelial cells. Okay. This affects all the vessels, venules, capillaries and arterioles. Now coming to the question, what has been asked, delayed prolonged response. It is because of direct injury. It takes at least 2 hours. Delayed means at least 2 hours it takes, and up to, it may start even after 12 hours also. 2 to 12 hours is the range. It is because of direct bacterial toxins or irradiation. Thermal injury or X-rays or UV rays can cause damage. Venules and capillaries are generally affected. There are 3 miscellaneous mechanisms. These first 3 what I have told are important mechanisms. The next 3 are miscellaneous. Leukocyte mediated injury, that is WBCs, neutrophils and lymphocytes are causing direct damage. That is that begins quite early and it affects all vessels, and the mechanism is because of proteolysis and reactive oxygen species that are generated because of leukocyte mediated injury. Leukocytes, cellular events. Okay, cellular events can also induce. Transcytosis is fluid passes through the cell. There are channels through the endothelial cells, okay, through which the fluid will pass without causing any damage. No detachment, no necrosis, no shrinkage, no contraction, no retraction, nothing. It is passing through and through. Okay, that is transcytosis. It begins early. It can happen through all the vessels, and the organelle that helps in transcytosis is called as vesiculovascular organelle. There is a vesicle as well as a vacuole formation that helps the fluid to move out. And finally, the last mechanism is neoangiogenesis. This takes a lot of time. New blood vessels have to form, and new blood vessels, as you know, are always leaky. New blood vessels are not strong vessels, they are very leaky. So, they leak out a lot of fluid, so vascular permeability is increased, the fluid can seep out or leak out. So, these are all the different mechanisms. On this, the questions that have been asked are, one is delayed prolonged response because of direct bacterial toxins or direct bacterial injury. Okay. Next is histamine affects which organs, it is which vessels, it is post capillary venules. Immediate transient response is induced by which mediator? Histamine is the most important mediator that induces immediate transient response. The type of mechanism that causes leakage of vascular fluid without damaging the endothelial cells is transcytosis, no damage at all. Vesiculovascular organs are seen in which mechanism? Transcytosis. These are some of the questions that have been asked on vascular events. Moving on to the next question, yeah, that is the answer. Next question is, which of the following statements about bradykinin is true? Now, these days I am finding that bradykinin has become a hot topic. They are asking plenty of questions on bradykinin because of its importance in so many different arms of inflammatory mechanism. It plays a role everywhere around. So, a lot of questions are asked. Bradykinin, which of the following statements is true? Okay, only one is true. It causes pain. It causes bronchodilation, it causes vasoconstriction, it decreases vascular permeability. Any guesses? Pain, causes pain. Okay, bradykinin definitely causes pain, but what about the other 3? Causes bronchodilation, they say bronchodilation in the option, causes vasoconstriction, decreases vascular permeability. Please remember from our previous table, apart from histamine, the next one there in immediate was bradykinin. So, it increases vascular permeability. Okay. All these days we believed that bradykinin is important for pain. Now we have realized that more important function of bradykinin than pain is increased vascular permeability. It causes edema at that site. But here the option says decreases, so it's not true. Okay. The other two options, bronchodilation, vasoconstriction. It causes bronchoconstriction because of smooth muscle contraction in the bronchial tree. Okay. Whereas blood vessels of the in general, all the arterioles and capillary and venules, they undergo vasodilatation, not vasoconstriction. How is this different? It also contains smooth muscle. You might be wondering, the bronchial tree contains smooth muscle, blood vessel also contains smooth muscle. Why this differential response? Bronchial tree is constricting, bronchoconstriction, whereas smooth muscles are dilating in the vessel. Why? Both have smooth muscles. The innervation is slightly different. If you get back to your physiology, it is sympathetic cholinergic pathway which innervates the blood vessels. In everywhere, all other smooth muscles, sympathetic adrenergic pathway, that is adrenaline is released as the mediator. Whereas in blood vessels, though it is sympathetic, the postganglionic fibers are going to release acetylcholine. So, it is sympathetic cholinergic pathway. As a result, there is going to be vasodilatation in the blood vessels. So, answer this is something from Robbins, which says that bradykinin, which belongs to the family of kinins, it belongs to the family of kinins. These are vasoactive peptides derived from kininogens. In plasma, there are a set of peptides which are circulating in a preformed state, which are called as kininogens. These kininogens are acted upon by kallikreins. The most important kininogen that is circulating in plasma is HMW, or high molecular weight kininogen, that is acted upon by kallikrein to produce bradykinin. Bradykinin is the active end product of kininogen group of molecules. Kininogen family produces bradykinin as their active substrate. Bradykinin increases vascular permeability, which we have already discussed. It causes contraction of smooth muscle in the bronchial tree, dilatation of the blood vessels, and pain when injected into the skin. Okay. These effects are same as that of histamine. Histamine, serotonin, that is 5-hydroxytryptamine, and bradykinin, all of them cause similar effects. That is, they cause dilatation of the vessels, they cause constriction of the bronchi. So, patient if asthmatic, if you give them histamine, bradykinin, they will start having asthmatic attacks, wheezing attacks. Okay. And then they will cause pain. They are mediators of pain. Bradykinin is very important mediator, but the most important thing I want to remember is increased vascular permeability. Okay. These effects are similar to that of histamine. The action is short-lived because it is quickly inactivated by enzymes that are circulating in the plasma called as kininases. Kininases are constantly circulating. They will degrade bradykinin. So, its effect is hardly half an hour to 1 hour. After that, the effect of bradykinin dies out. Okay. Bradykinin has been implicated as a mediator for allergic reactions, especially anaphylaxis. So, here we are going to a very important table which tells us the role of, the most important role of the mediators in inflammation. Okay. There are overlapping roles. We have seen that every mediator does every function, but what is their main function? We are going to see in this table. Vasodilatation is mainly brought about by histamine, short-lived effect. Okay. Short-lived, but very important amount of vasodilatation is brought about by histamine, but later on the job is taken over by prostaglandins. Okay. Increased vascular permeability, histamine, serotonin initially, later on C3A and C5A, which are products of complement cascade, and then leukotrienes, LTC4, D4 and E4. Leukotrienes are very important agents which potentiate vascular permeability. Chemotaxis, that is recruitment of cells to the site of inflammation, the cellular events. The cells have to be brought to the site of inflammation. This is done by TNF alpha, especially tumor necrosis factor alpha, interleukin 1, chemokines, it is a family. Okay, chemokines, it is a family of, there are 4 subtypes of chemokines which we will see in a subsequent question. Then C3A and C5A, which also induce chemotaxis. They are chemotactic, they are anaphylatoxic, and they increase vascular permeability. C3A and C5A. Whereas the C3B and 5B components remain in the complement cascade. Complement cascade, the activated complements are being broken down into A and B components. A is doing this function, B is attached there only. Okay. Leukotrienes B4 also cause chemotaxis. Fever is mediated by interleukin 1, interleukin 6, tumor necrosis factor, interferons and prostaglandins. All these are mediators of fever. They are pyrogenic. Most important, please remember IL-1, interleukin 1. Okay. Pain is mediated by prostaglandins again, bradykinin to some extent, and then of course substance P and neuropeptides are also implicated in pain. Tissue damage. The enzymes that are released from the lysosomal granules, that is the proteolytic enzymes, they cause maximum tissue damage. Next amount of tissue damage is caused by reactive oxygen species. Okay. These are the important functions of each of these mediators. Now that is the answer, bradykinin causes pain. Most characteristic feature of acute inflammation is, slightly tricky question, vasoconstriction, vascular stasis, vasodilatation and increased permeability, margination of leukocytes. Now if you look at the options, all 4 occur in acute inflammation. All 4 are features of acute inflammation. Initially there is very transient vasoconstriction. Whenever there is acute inflammation or damage to the vascular endothelium or injury to the vessel, initially the first response is always vasoconstriction. Okay? The vessel suddenly constricts. This is because of the neural loop which is present in the blood vessel. This has got nothing to do with the mediators. Mediators cannot act so fast. Okay? There is a neural loop which causes sudden transient vasoconstriction whenever the vessel is damaged by inflammation. Okay? This is followed always by vasodilatation, increased vascular permeability that will seep out all the fluid from the that particular area. Fluid will come out from intravascular compartment to the interstitial space. That will increase the concentration. Increased concentration will cause vascular stasis. Vascular stasis will bring about more of the mediators of chemical mediators of inflammation as well as the cells which are going to play a role in cellular events. Okay. So the cellular events will begin, then the cells will start marginating, the first step, then they start rolling, then they start attaching to the endothelium, they come out of the between the endothelial cells which is called as diapedesis, then they are taken to the site of inflammation they are guided by chemotaxis. So by chemotaxis they will reach the site of inflammation and then they will perform their function, mainly phagocytosis, they will carry about phagocytosis. So vascular cellular events, all these are part of inflammation. He is asking specifically what is the most characteristic feature which has to happen, without that inflammation cannot happen. The most important is everything is centered around increased vascular permeability. No increased vascular permeability, nothing will happen. Permeability has to increase, because without that the chemical contents and the cells cannot come out. Okay. So the option here, correct answer here is C, vascular dilatation and increased vascular permeability. Action of bradykinin include all of the following except. We already have discussed this, so you should tell me the answer. Okay, it causes bronchoconstriction. So option given is bronchodilation, which is the wrong option. Vasodilatation, yes, it does vasodilatation, it increases vascular permeability, it causes pain. So we'll go for option B. Answer is B, right. I think that's repeated. What is the most important role of bradykinin in acute? Okay, this is slightly different question, not repetition. In this question they are asking about the most important role of bradykinin. All are the roles of bradykinin only. Okay, as I discussed before, all these days we thought it's pain, but now this, when asked in 2010, most of the answer keys said increased vascular permeability. Definitely it is increased vascular permeability. Okay, again I think repetition of the same question. Answer is C. Macrophage activation syndrome is characterized by all of the following except: activation of CD8 plus T cells, presence of cytokine storm. It is the other name for hemophagocytic lymphohistiocytosis, low levels of plasma ferritin. Macrophage activation syndrome is a syndrome in which there is widespread activation of histiocytes and macrophages of the reticuloendothelial system throughout the body. Throughout the body there is widespread activation in the bone marrow, in the spleen, in the liver, in the lymphoid organs of the GI tract, respiratory tract, Walde's ring, everywhere macrophages will get activated and they will start phagocytosing. As a result, you get increased digestion of the parenchymal cells. So, obviously, the synonym or the other name for this syndrome has to be hemophagocytic syndrome, increased phagocytosis, especially in the bone marrow. Especially in the bone marrow, they are causing increased phagocytosis of all the precursors of the hematopoietic system. Erythroid precursors, myeloid precursors, lymphoid precursors, all precursors are being digested. So, the other name is hemophagocytic lymphohistiocytosis, or just called as hemophagocytic syndrome. Okay. So, option C is correct. All are correct except one is wrong. Only one is wrong. Which one is wrong? We will see. Whenever these phagocytes get activated, they secrete varieties of cytokines like gamma interferons, tumor necrosis factor, interleukin 1 in increased amount. Especially gamma interferons are secreted. Gamma interferons will further activate other macrophages. They will also activate the T helper 1 population, further causing secretion of T helper 1, causing further secretion of interleukin 2 that recruits more and more of T helper 1 cells. So, this is called as cytokine storm. Cytokine storm means what? Lot of cytokines are released throughout the body, especially tumor necrosis factor, interleukin 1, both are more or less same. Their function is more or less same, IL-1 and tumor necrosis factor. Gamma interferons and interleukin 2 by the T helper 1 population. Okay, T helper 1 producing interleukin 2. T helper 2 also sometimes gets differentiated and produces interleukin 4, interleukin 5, interleukin 13. Interleukin 5 will recruit more and more of eosinophils. So, what is happening? A cascade is being set up. One cell secreting so many cytokines, other cells being recruited, those cells are further secreting cytokines. So, this is called a cytokine storm. Cytokine storm is a characteristic feature of hemophagocytic syndrome, also called as macrophage activation syndrome, both are synonymous. So, there is cytokine storm. As a result, finally, which cell gets activated is CD8 plus cytotoxic T lymphocyte, which is causing direct cytotoxicity. As you know, the T lymphocytes are basically of two types, CD4 plus and CD8 plus. CD4 plus we call as helper T cells, CD8 plus we call it as suppressor or cytotoxic T cells. CD4 plus or helper T cells are further differentiated into two subgroups, helper 1, helper 2. Okay. We will discuss in detail about helper 1 and helper 2 later on. Okay. Now, at this point, CD8 plus is cytotoxic or suppressor T cells whose job is to directly destroy the cell. That it does by one important mechanism or pathway called as perforin granzyme pathway. This is an MCQ. This is asked several times. CD8 plus or cytotoxic T cells are going to damage or kill cells. Which cells they kill? Generally, they target virus infected cells. They directly kill the virus infected cells by perforin granzyme pathway. What they do is they have a drilling machine called as perforin, which drills hole into the cell membrane of that target cell. There is a target cell, its cell membrane is there, a hole is drilled. What will happen if a hole is drilled in the membrane? All its contents will come out. If it loses all its content, it will shrink and it will die, right? So, that is how the cytotoxic T cells are going to kill. They get activated in macrophage activation syndrome secondarily. So, what is wrong is low levels of plasma ferritin. Now, just imagine whenever there is so much of damage to the epithelial cells of liver, epithelial cells of intestine, epithelial cells of spleen, okay, there is whatever iron is stored in those epithelial cell will be released. That iron has to be engulfed by the macrophages. Okay. Meanwhile, before they engulf, the plasma levels of transferrin are going to increase. Iron levels in the plasma, serum iron levels are going to increase. Iron is always stored in the form of ferritin. The storage form of iron, there are two storage forms of iron, ferritin and hemosiderin. Ferritin and hemosiderin. The difference, again, there are plenty of MCQs on this topic. Ferritin is reversible form, whereas hemosiderin is irreversible form. From ferritin you can retrieve iron, from hemosiderin you cannot retrieve iron. Ferritin is non-stainable form of iron, whereas hemosiderin is stainable form of iron. The stain which we use to detect iron in tissues is Pearl's Prussian blue. It is called as Pearl stain because MCQs they use different terms. Sometimes they ask only Pearl stain, sometimes they ask Prussian blue, sometimes they ask Pearl's Prussian blue. So just remember the full name, Pearl's Prussian blue stain. Okay. So in this syndrome, serum iron increases, as a result transferrin saturation increases, as a result the storage forms are going to increase, the most important storage form being ferritin. So plasma ferritin levels are going to be increased. Here the option says low levels, so that is the wrong option here, except D. Which cells of the mononuclear phagocyte system are present in a liver? Serum? Because of damage to the epithelial cells. The macrophages are causing digestion. When they cause digestion, they can store some amount of iron. They have a capacity, limited capacity to store iron. They have to deliver that iron to the hematopoietic progenitor cells in the bone marrow, which are dividing very fast. They will need iron for hemoglobin synthesis. So they deliver that. The extra amount of iron which they cannot digest is regurgitated back into the plasma, interstitium. That enters the plasma. From the lymphatics it enters. So because of whenever there is a lot of cell damage, whenever a lot of cells are damaged or digested, be it widespread necrosis, be it neoplasm or neoplastic injury, lot of iron is thrown out. There is a capacity for macrophages to digest. Beyond that, they have to regurgitate. That comes into the plasma and levels of serum iron will rise. So obviously serum ferritin will also rise. Okay. Mononuclear phagocytic cells in different organs. There are macrophages present in all organs of the body. They have been given different names according to the site. In liver, the name given to them is Kupffer cells. Kupffer cells is the name given to the macrophages present in liver. Okay. The word macrophage and histiocyte are synonymous. Please remember, in pathology MCQs, wherever they use the term macrophage and histiocyte, they are more or less same. But the word histiocyte means macrophages in tissues. Histio means tissue. Tissue macrophage. Okay. Macrophage is a broad term and it's a system. We call it as monocyte macrophage system. Okay. When present in tissues, histiocytes. In different tissues, they have been given different names. For example, in skin, they are called as dendritic cells and Langerhans cells. Okay. I think I might be having a table on the different macrophages later on. We will see the names. In skin, they are called as dendritic cells and Langerhans cells. Langerhans. Okay, not Langhans. Please don't confuse. Langhans is a multinucleated giant cell seen in tuberculosis. Okay, multinucleated giant cells with horseshoe-shaped arrangement of nuclei is called as Langhans giant cell, whereas Langerhans is a type of macrophage present in the skin. Okay. Similarly, in lymph nodes also you have interdigitating dendritic cells which are macrophages present in the lymph nodes, interdigitating dendritic cells. Okay. In liver we have Kupffer cells, in CNS we have microglia. Microglial cells are the macrophages present in the central nervous system. Okay. In the respiratory tract we have alveolar macrophages. In the respiratory tract we have alveolar macrophages. In spleen we have accordingly splenic macrophages that are going to perform this function. Okay. These are the names of different cells. Merkel cells, Gator cells, Berger cells are not truly macrophages in their function. Okay. Non-professional antigen presenting cells, all except endothelial cells, epidermal cells, fibroblasts, red blood cells. Okay. Antigen presenting cells. What are antigen presenting cells? They are the first line of defense in the body. Whenever any infectious agent comes, injurious agent comes from outside, okay, it has some antigens on its surface. Those antigens are not directly recognized by the lymphocytes. They have to be processed. So who does this processing work? This processing work is done by antigen presenting cells. Their job is to take the infectious agent, process it, okay, and remove the antigenic points. The specific points of antigen are known as, which are going to elicit antibody response, are called as the parts of antigen, the specific components of antigen that are going to elicit an antibody response. This is again an MCQ. They are called epitopes. They are called epitopes. And the corresponding part of the antibody that is going to interact with the epitope is called as a paratope. Epitope and paratope. So epitope, the process of processing the antigen to expose all its epitopes is called as antigen processing. This is done by the APCs, antigen presenting cells. Where are these cells present? Antigen presenting cells are present at all the portals of entry inside the body. Skin. In the skin, antigen presenting cells are present. GI tract, from where infections can enter, antigen presenting cells are present. Respiratory tract, antigen presenting cells are present. Urinary tract, genital tract, all these hollow viscera, antigen presenting cells are present. Okay. Now, they are, after processing the antigen, they are going to present them to the lymphocytes along with MHC molecules. This is called as MHC class restriction. Okay. As you might be already aware that MHC class restriction is there for helper T cells, okay, and cytotoxic T cells. For helper T cells, the antigen APCs have to present with class 2, okay, MHC class 2 for helper, and for cytotoxic or CD8 plus MHC class 1, that is called as MHC class restriction. Okay. Now, these antigen presenting cells are broadly divided into two groups. That is our question. The question is on professional and non-professional. So, just apply common logic. Which would be professional? The ones who are doing this job on a daily basis are called as professional. So, out of these, any professional cells we are finding? No, none of these are professional. They are all non-professional. Okay. All these are non-professional except one. All these are non-professional except one. So, just we will have a quick look at which are professional, which are non-professional. So, antigen presenting cells, professional ones are the ones which carry MHC class 2 molecules, and they do this job on a daily basis. Dendritic cells and B cells are the most important professional antigen presenting cells. Dendritic cells, as you know, are macrophages in the skin and lymph node. Their job is to present antigens on a daily basis. So, they are professional. B cells are also professional. Whereas, non-professional cells are all cells that carry MHC class 1 antigens. Okay. At this point, let us recollect one very important fact quickly. MHC class 1 is present on all cells which have nuclei in the body, all nucleated cells. Please remember this golden rule. All nucleated cells will contain MHC class 1. So, can you tell me two cells which will not contain the MHC class 1 because they do not have nuclei? RBC and platelets. Excellent. RBCs and platelets do not have nuclei, so they do not contain MHC class 1 molecule. MHC class 2 is very specialized molecule. It is present only on cells of the reticuloendothelial system which are involved in immunity. Which are they? The macrophages, especially which macrophages? Dendritic cells, Langerhans cells, and to some extent B cells. Okay. So, class 2 containing APCs are all professional, class 1 containing are all non-professional. Now, going by this logic, all nucleated cells are non-professional. Okay. So, endothelial cell contains nucleus, so it is non-professional. Fibroblast contains nucleus, it is non-professional. Epithelial cells contain nucleus, it is non-professional. RBC does not contain nucleus, it is non-professional, neither professional nor non-professional. Okay. If it is non-professional, it does not mean it is professional. Okay. It is not professional also. It is not at all an APC. It is not at all an APC. Right. So, answer here is RBCs. I hope I have not confused you on this topic. Right. Which cells? Okay, the repetition of the same thing. Kupffer cells has been asked several times. Increased vascular permeability in acute inflammation is due to, as we saw from the table, histamine is the most important mediator for increasing the vascular permeability. Okay. Right, moving on to the next question. Leukocyte adhesion to the endothelium is mediated by all of the following except. Now, there are three important families of leukocyte adhesion molecules: selectins, integrins, and immunoglobulin superfamily. Initially, there was a fourth family called as mucin-like glycoproteins, which is not considered very important these days. So, it's been reduced to three families: integrins, selectins, and the immunoglobulin superfamily. These are the three important leukocyte adhesion molecules. They are called as LAMs. Okay. Out of these, selectins are of three types: E-selectin, L-selectin, and P-selectin. Okay. E-selectin, L-selectin, and P-selectin. E-selectin is expressed mainly on the endothelium. L-selectin is expressed on the leukocytes, and P-selectin is expressed on the platelets, ELP. The names are self-explanatory. Selectins have a role mainly in rolling and margination of the leukocytes. Selectins help the leukocytes to roll. Now, you should understand this important thing, then you can answer hundreds of MCQs on this question, on this topic, because a lot of MCQs are asked on inflammation chapter. So, I do not want to rush through this chapter. Whenever cells are flowing in a regular normal blood flow, which we call it as a streamlined blood flow, okay, non-turbulent streamlined blood flow, cells are all in the center and plasma is there in the periphery. Okay, cells are moving in the center in a single row. Okay, this is called a streamlined flow. Cells are in the center, plasma is in the periphery. Now, okay, cells are going this way. Now, suddenly at that point something happens, some injury happens at that point. So, at that point we want the cells to come out, okay, move out of the blood vessel and cause phagocytosis or whatever it is. Okay. For that reason the cells have to move to the periphery. So, it's like a ring road, you can imagine, a very fast road in which vehicles are moving very fast. So, all the fast moving vehicles will be in the central lane. So, first you have to come to the peripheral lane. If you want to come out of the ring road and enter a sub road inside the areas, you have to come to the periphery, outer lane. Okay, from the central lane you have to come to the peripheral lane. So, this is called as margination. The cells start marginating. After marginating, if from the central in the central lane you are moving at a speed of 140-150 kilometers per hour, okay, you have come to the peripheral lane where you are going in 70-80 speed. You have marginated. Now, you have to decrease your speed. To exit, to take a left turn, you have to decrease your speed. You have to come to 30-40 speed. Okay, this is done by rolling. Because the cells are moving at a very fast rate, they roll on the endothelium. Because of rolling, their speed decreases. This rolling is brought about by selectins. Selectins are receptors and ligands which are expressed in an on and off fashion. Okay. So, they are expressed, that is, they are switched on. The cell will bind, the leukocyte will bind to the endothelium. It is switched off suddenly. So, the interaction is lost. So, then it moves further. Again, it is switched on, it binds, it is switched off, it moves further. So, because of this switch on, switch off, switch on, switch off, the cell keeps moving, it does not stand there. Because if you suddenly stop a vehicle which is moving at 140 or 8, even for that matter 80 also, suddenly if you apply brakes, then there will be damage, right. So, even if the cells which are moving very fast, if they suddenly stop on one endothelial cell, they will damage the endothelial cell. So, we want them to slow down. This is exactly comparable to the traffic rules. Okay. So, once they slow down, and who does this slow down? By this selectin on and off mechanism. Once they slow down, once their speed decreases, integrins are expressed. Integrins are like dividers which are present, which are going to give you a way out. Okay. Integrins are strong interactions. So, they will stop the cell there. Selectins are not strong, they are low affinity interactions. These integrins are high affinity interactions. Selectins will just slow down, whereas integrins will stop the cell. Integrins will help the cell to bind to the endothelium, and then the cell, after binding to the endothelium, in between two endothelial cells, it undergoes squeezing, which is called as diapedosis, and the rest you know, it undergoes chemotaxis and reaches the site. Okay. Now, here we are talking about leukocyte for this mechanism we require 3 molecules mainly, as you have realized. One is selectins for slowing down, which we called as rolling. We called it as rolling. Second is integrins for high affinity interactions for binding, adhesion, we call it as adhesion. And then some for these receptors we will need ligands on the leukocytes also. Those ligands are VCAM, vascular cell adhesion molecule, okay, and ICAM. VCAMs and ICAMs are adhesion molecules that are expressed as ligands on these cells. Of these VCAMs, now you have to just remember VCAM1 is the most important VCAM that is expressed. ICAM1 and VCAM1 are important molecules. So, now let us list all the important adhesion molecules. Among the selectins we said 3 types, E-selectin, P-selectin and L-selectin. Among the integrins there are 2 types, alpha integrins and beta integrins. Okay. Alpha integrins and beta integrins, there are 2 examples, VLA, very late activating molecules, VLA, and LFA molecule. Okay. Leukocyte factor antigen, LFA and VLA molecules. Just remember the names, or just remember alpha and beta integrins. Okay. But these days they are also asking MCQs on their CD molecules. So just remember, integrins have two important CD molecules, CD11 and CD18. CD11 and CD18 are too important. See, it's all about accumulating as many facts as possible. So try to remember this. CD11, CD8, whenever these two molecules come to your mind in a combination, it is about integrins. It is about integrins. Okay. Then the third one is VCAM and ICAM. Okay, VCAM and ICAM. Among VCAM, VCAM 1, among ICAM, ICAM 1. So of these, now you tell me which is the one that is not fitting in the list we have generated. Selectins, of course, both L and E, VCAM 1 is present. VCAM 4 we have not heard of. So all of these are answers. Okay, very quickly I will go through this. I have told most of this, I have already told, so I will quickly rush through this. Selectins L, E and P selectin. L selectins are expressed on leukocytes side. Which leukocytes? Mainly neutrophils. Mainly neutrophils, to some extent even monocytes, T lymphocytes and B lymphocytes also. The ligands for this are silyl Lewis molecules, silyl Lewis molecules, or they are also called as glycam. For all of these, number 1 is very, very important. All their subtypes, ones are important. So glycam 1 is important and madcam 1 is also important. Okay. CD34 is a molecule that is expressed by the vascular endothelial cells. Okay. We have a high yield topic on CD markers. Okay. On that we will make a list, but as of now keep remembering, if I throw all the molecules on you simultaneously, you can't register. So keep registering. 34 and 31 are for blood vessels. 34 and 31 are for blood vessels. Endothelial cells of the blood vessels are going to express 34. Okay. E selectin on endothelium, it is expressed by the E for endothelium, right? Self-explanatory. Endothelium, it is activated by, or it is induced by TNF alpha and interleukin 1. This has been asked in all the entrance examinations as a common MCQ. E selectin expression by endothelial cells is activated by, what makes the endothelial cells express E selectin? It is TNF and interleukin 1. So now you can imagine the whole process is a circle, it is a loop. How it is a loop? The endothelium gets activated. Okay, there is injury at the site. First, the inflammation begins with injury. Always there has to be injury. Injury, increased vascular permeability, activation of the endothelium. Okay, cytokines are coming. Which cytokines? Interleukin 1 and tumor necrosis factor. They are again further activating endothelium. Endothelium is expressing selectin, especially E selectin. Cells will come. Cells will secrete more cytokines, TNF alpha and interleukin 1. Again endothelium gets activated. So it's a vicious cycle, not just a cycle, it's a vicious self-perpetuating cycle. Somebody has to come and stop. Some anti-inflammatory cytokines have to come. Most important is TGF beta. TGF beta has to come and stop this process. Until then, this inflammation continues. Okay. So E selectin. For E selectin also the ligand is silyl Lewis. Please remember, silyl Lewis molecules are ligands for selectins. They are expressed on neutrophils, monocytes, T cells, all of them. P selectin is expressed endothelium activated by endothelium activated cytokines, histamine or thrombin. All of them are going to induce P selectin. Okay. For selectins, the molecule, the CD molecule is 62. For selectins, the CD number is 62. Okay. For P also it is silyl Lewis. So for selectins, what we have learnt about selectins, there are 3 types: L selectin, P selectin and E selectin. For the common CD molecule for selectins is CD62. Okay. L selectin is expressed on leukocytes, E selectin on endothelial cells and P selectin on both endothelial cells and platelets. For them, the most important inducers are TNF and interleukin 1, and the ligands for these selectins are silyl Lewis molecules, and glycam 1s and madcam 1s, all 1s are present here. Okay. Now coming to integrins, as I told you before, the CD molecules I have already told you which you have got registered, that is CD11 and CD18, CD11 and CD18 are molecules for them. I told you about 2 important ones among them, LFA, that is late leukocyte factor antigen, and then VLA is very late acting molecule, LFA1 and VLA4. These are expressed by, as you can see, they are distributed by, integrins are distributed in all the inflammatory cells like neutrophils, monocytes, T lymphocytes, and yeah, of course, monocytes, T lymphocytes. All the inflammatory cells are going to express integrins. For these integrins expressed by leukocytes, the ligands are ICAMs. ICAM 1, ICAM 2. 2 is also important, but the most important is ICAM 1, as you can see from there, and VCAM 1. VCAM 1 for VLA and alpha 4 B7, beta 7, VCAM 1. So forget all the 3s, 4s and all that. So remember 1s are the most important for CAMs. CAMs are cell adhesion molecules. For CAMs, ICAM and VCAMs, 1s, that is the first subtype is most important. ICAM 1 and VCAM 1. Okay. So integrins. Integrins are high affinity interactions. Selectins were low affinity interactions. Selectins helped in rolling, whereas integrins help in binding or adhesion. Okay, high affinity interactions. The CD molecule for integrins, CD 11 and 18. Okay, integrins are expressed by which cells? They are expressed by all leukocytes. Which all leukocytes? Neutrophils, monocytes, T cells. All cells are going to express integrins. For integrins, the ligands are CAMs. Which CAMs? ICAMs and VCAMs. Which subtypes? 1. Subtype 1. Okay, just remember these facts. Immunoglobulin superfamily, I am going to give you only one example, CD31, the most important one, which is expressed by the endothelial cell, and it binds to another endothelial cell that expresses CD31. So these are called as homotypic interactions. Okay, so any cell that expresses CD31, it will bind to CD31. Same CD31 acts as receptor also, same CD31 molecules also acts as ligand. So when the receptor and ligand is same, these interactions are called as homotypic interactions. Same receptor, same ligand. Okay, that is CD31. This is about cell adhesion molecules or leukocyte adhesion molecules.